welcome Dr. Chiu and Dr. Pan to our from Oncology Frontier and Oncology Frontier. Let's get the first question to Dr. Chiu. More than half of newly diagnosed prostate cancer patients in China are already at an advanced stage. Based on your clinical experience, what are the urgent diagnostic and treatment challenges that you believe need to be addressed? Thank you.
Okay, very good question, huh? Like you mentioned, more than 50% of the newly diagnosed prostate cancer patients in China are locally advanced or advanced. Actually, it's kind of high compared with the situation in the Western countries like the United States. I think the main reason for this is that we don't have, the nationwide PSA screening in China. So in our clinical practice, we have two challenges. The first one is to recommend a PSA test for those old men with lots symptoms. And the second one, I think, is to trying to conduct the PSA screening in some economically developed cities like in Shanghai or Beijing, try to see the effect of the PSA screening. Yeah, that's my answer. Thank you.
Thank you, Dr. Zhou. Next question to Dr. Poon. Precision therapy has now entered the field of prostate cancer. Could you share, based on the relevant data and clinical experience, how to select a precision treatment for Chinese patients with metastatic, hormonal-sensitive prostate cancer? Thank you.
Thank you for your questions. I think precision medicine is very important in managing our prostate cancer patients because we understand that a substantial proportion of patients could harbor actionable mutations like BRCA1, BRCA2, or HRR mutations that may benefit from the PARP inhibitors, as well as some patients, although they are not in the majority, maybe less than 5% of patients may having the microsatellite instability that may also benefit from the immune checkpoint inhibitors. So we have some experience in Hong Kong. We have conducted some liquid biopsy study showing that around 36% of patients did harbor HRR mutations. And among these patients, 9.9% of patients had BRCA1 and 2 mutations. And we have published and presented our data in ESMO Asia, and that this subgroup of patients really impact their treatment decision, and they had been benefit from the use of the PARP inhibitors. And apart from the therapeutic implications, I think one may be not aware is about the familial implications because some of these patients, apart from the somatic mutations, they may having the germ9 mutations. So that will be having some familial implications, and we should offer germ9 mutations, and then we can offering them with the genetic counseling. And especially if they have some germ9 mutations, that may causing a lot of influence in their offspring or in their families. So I think the second important implications about the genetic mutation, genetic analysis is the genetic counseling for these prostate cancer patients, especially among their families.
Okay, thank you, Dr. Poon. Next question to Dr. Chiu. You presented the PROACT study at this year's ASCO GU conference. What are the clinical implications of this study for MHSPC patients with HRR alerted? Thank you.
Thank you for this question. Actually, I think PROACT is a very interesting study. We enrolled patients, actually the metastatic hormone-sensitive prostate cancer patients who had the HR mutation to join our study and get them the combination of PARP inhibitor olaparib and the AR pathway inhibitor abiraterone, and to see the safety and the efficacy of the combination of these two medicines. And the current data show that the the ORR rate in 30 patients is about, I think, is about 84%. And we still need to wait for long-term oncological outcomes. Another thing I need to highlight that this is a single-arm phase 2 clinical trial. So we don't know the comparison between the monotherapy like abiraterone or enzalutamide compared with the combination for the treatment of patients with MHSPC. So maybe in the future we will have this kind of phase 3 clinical trials. Actually, I have a question for Dr. Pan. In yesterday's presentation, TALAPRO-2 released its final OS data. Actually, it's kind of different from the OS data in the PROPEL trial. So, do you think patients, without HR mutation in the mCRPC population could get the benefits from the combination of talazoparib and enzalutamide?
Yeah, I think in the TALAPRO-2 study that has been presented in ASCO GU Day 1, which has the updated data showing there is an overall survival benefit in all comers. But I think I still consider the combinations of ARPI together with prior emitters in patients with HRR or BRCA1 or 2 mutations, because if you see the subgroup analysis, the overall survival benefit was more substantial in the BRCA1, 2 or the HRR mutation populations, whereas for the all-comers or the ITT populations, the benefit or overall survival benefit was less substantial. I think this will be very important because you know that the combination treatments, especially in the TALAPRO-2 trial, some patients experience grade 3 anemia that require blood transfusion, and this will causing a lot of quality of life impairment. So we have to balance the risk and the benefit for the offering the combination treatments, especially in the overall, the ITT population, all comers, because otherwise, if the overall survival benefit is not very dramatical, but they have suffering from the side effects from the combination treatments, so there's a trade-off. But for the BRCA2 or 1 mutation or HRR mutation patient, they really benefit from the combination treatments in the mCRPC setting. So I think I will still, at least I will check the genetic testing for our mCRPC patients. If they have HRR or the BRCA1, 2 mutation, I will discuss with them about the options of the combination treatments.
Okay, let's move the next question to Dr. Poon. For patients who progress to mCRPC, which value does NHA therapy hold? In clinical practice, how do you selectively choose a regimen that balances both patients' survival and quality of life? Thank you.
Yeah, the novel hormonal agents or the ARPI, say for example, abiraterone and enzalutamide, has been the standard of care for mCRPC patients for more than 10 years. I think these ARPI has been putting up front in the MHSPC setting nowadays. So for the mCRPC patients, mostly they have been already exposed or experienced the use of the ARPI. Yes. But still, there's a portion of patients in the mCRPC setting, they haven't been given any NHA before, ARPI before. Say, for example, for those patients has been given upfront chemotherapy instead of ARPI, and then progress into mCRPC setting. So I think my personal experience or the objective is to try to give the patients with ARPI in any disease setting like MHSPC or mCRPC. For mCRPC setting, I think both abiraterone and enzalutamide has been registered as one of the ARPI in the mCRPC setting. But nowadays, I think the combination treatment is getting more popular. In the ASCO GU this year, we have at least two randomized control trial has been evaluated to investigate the combination approach. First is the TALAPRO-2, which evaluate the combinations of enzalutamide and the talazoparib. And the second approach that has been presented yesterday is the ENZA-P trial, which is the combinations of lutetium together with enzalutamide. And then both studies show benefit in terms of the overall survival compared to the enzalutamide monotherapy alone. So this raises a very important and interesting discussion is the combination approaches is not only been demonstrated with benefit in MHSPC setting, even in the MCRPC setting, the combination approaches is getting more important nowadays. So, but on the other hand, we have to balance about the side effects and the subsequent quality of life impairment. Like what we have discussed just now, the TALAPRO-2 trials, the combinations of talazoparib and the enzalutamide could bring 40% of patients with blood transfusions, and this will causing a quality of life impairment. So we have to get a balance between the benefit and the risk of these combination treatments. If you compare different combination approaches, like the PROPEL, you can see that the olaparib together with abiraterone seems the rate of anemia is a little bit lower compared to talazoparib together with enzalutamide. So if we choose any kind of combination treatment, we have to consider not only the efficacy, we have to also consider about the side effects in order to provide better survival as well as to maintain or to improve their quality of life.
Actually, I have a question for Dr. Pan. So for this kind of patients with MCRPC who used like the abiraterone or enzalutamide when they are MHSPC, so for this kind of patients, what kind of therapy would you like to recommend for this kind of patients?
So that's a very good question because you know the abiraterone, enzalutamide or other ARPI has been putting more upfront in the MHSPC setting. If they progress, I think into the MCRPC setting, these ARPI may not be considered at the frontline setting. So I usually will consider the other options. Firstly, I will check the genomic alterations. If the patients harbor kind of actionable mutations like BRCA, BRCA1 or 2 or HRJ mutation, definitely I will offer them with the PAR inhibitors like olaparib. If there is no actionable mutations, other options will be including the chemotherapy like docetaxel or cabazitaxel. And the other options will be doing the PSMA PET-CT scan to see whether the patient is eligible to lutetium 177 radioligand therapy. Because based on the VISION trial, we know that the lutetium 177 PSMA therapy provides survival benefits compared to the switching to the other lines of the ARPI. And nowadays, we know that from the PSMA-4 trial, the lutetium treatment has been showing a better survival outcome in patients without any prior chemotherapy. So I think lutetium is also one of the important treatment options for these MCRPC patients.
Yeah, another question for the same patient. If you give them the gene test and show they have the HR mutation, like BRCA mutation, so will you give them the PARP inhibitor monotherapy or combined with another, AR pathway inhibitor?
Yeah, it really depends on the whether the patient has been given ARPI before.
In the MHSPC period, they have received the
ARPI.
Yeah.
So because all those three randomized control trials, like the Managil, like the PROPEL, like the TALAPRO-2, they have been conducted in a very early stage, early years, and at that time, most of the patients haven't been given any ARPI in the MHSPC setting. Maybe TALAPRO-2, around 10% of patients has been given ARPI in the MHSPC settings. So the value or the benefits of the combination of PAR inhibitors together with ARPI in MCRPC patients that has been given with ARPI before, we really don't know the real benefit, whether the combination treatment really bring important survival benefit to them. Because especially you know that for patients who progress on ARPI and then we switch to the other lines of ARPI, the objective response rate or the PSA response is only around 5 to 10%. We know that if they fail refractory to ARPI, it's going not to be helpful to change to other ARPI. So whether adding a PAR inhibitors will enhance the ARPI response, even if they have progressed with another ARPI, we really don't know. So personally, I think I would not offering patients with combination treatments if they have progressed on the ARPI. Certainly, it also depends on the interval between the progression and the last ARPI exposure. If they have progressed very shortly after the previous ARPI, I definitely not offering the combination ARPI together with PAR inhibitors. Yeah.
Thank you.
Okay, many thanks to our two professors on sharing their opinions on ASCO GU, and we hope to have more opportunities to discuss next time. Thank you very much.
Thank you.